Hello, my name is Ariane Lemieux, and I will be talking through the poster Sheenhan syndrome causing severe combined systolic and diastolic heart failure. Endocrinopathies can commonly cause reversible cardiac complications. These typically include those of the pituitary gland, the thyroid gland, parathyroid gland, or adrenal gland. Focusing on the pituitary gland, malfunction caused by panhypopituitarism can cause severe left ventricular dysfunction and cardiac shock. A specific type of panhypopituitarism, Sheenhan syndrome, occurs postpartum due to decreased pituitary blood flow. We present a case of a 29-year-old patient who presented with panhypopituitarism caused by Sheenhan syndrome, which caused severe combined systolic and diastolic heart failure. In this case, a 29-year-old woman presented with a past medical history of hypothyroidism, and her chief complaint was weakness, cold intolerance, nausea, and vomiting. She had stopped taking her thyroid medication years ago, and also noted that in her last pregnancy 6 years prior, she has had amenorrhea, hair loss, fatigue, and facial swelling since then. She also noted she had been diagnosed with heart failure 2 years prior, and records show that the ejection fraction then was 25%. Her initial vitals showed a temperature of 94.5, a blood pressure of 94/75, a pulse of 71, and she was breathing normally on room air. Her physical exam was grossly unremarkable. Her initial labs were remarkable for a glucose of 32 and a T4 of 0.23. She was started on a continuous infusion of D5 in order to correct the hypoglycemia, and she was also given an external warmer, a bear hugger, in order to increase her temperature. Afterwards, her temperature increased to 97.5 degrees Fahrenheit. Subsequent labs showed that her AM cortisol and her ACTH were both low. Her insulin-like growth factor was also low. Her T3 was low. Her prolactin and her LH were also low. She was subsequently started on hydrocortisone 50 milligrams every 6 hours and showed symptomatic improvement. Her levothyroxine was also increased to 100 micrograms every day. Estrogen and growth hormone therapy were considered but not immediately started. To evaluate the anatomy of her pituitary gland, an MRI of her brain was completed. It showed flattening of the anterior pituitary consistent with partially empty cella syndrome, as seen in the image where the arrow is pointing. To evaluate her heart failure, a transthoracic echo was completed. It revealed severe combined systolic and diastolic cardiomyopathy with an ejection fraction of 10%. She was treated with hydrocortisone and levothyroxine for hormone replacement long-term, and for her heart failure, she was treated with diuretics, digoxin, and an ACE inhibitor. In conclusion, this case highlights how endocrinopathies can lead to severe combined heart failure, particularly in young patients. Importantly, treatment of these endocrinopathies can typically result in improvement of cardiac function. The references are listed on the poster. Thank you for listening.